Welcome back to RadOnc Smart Review, Thoracic Edition. You can spend days, maybe even weeks, perfecting a thoracic radiation plan.
Oh, absolutely. The dose distribution on the screen usually looks like a total work of art.
Right. I mean, the critical constraints are met, the target coverage is mathematically flawless, the conformity index is like something you'd want to frame on your wall.
It's beautiful in theory, but then your patient actually lies down on the treatment table.
Yeah. And they take this shaky, irregular, exhausted breath, and that digital masterpiece just instantly shatters.
It really does, because that collision between the idealized plan and the physical patient is exactly where every hidden vulnerability in our workflow gets exposed.
So today, we are exploring that exact moment, when our static plans violently collide with moving, breathing human reality.
We are dealing with highly dynamic anatomy here. The central challenge you face in the clinic isn't just the biological fact that a tumor moves inside a lung.
Right, it's way more than that.
Exactly. The real trial is the immense difficulty of ensuring that the initial snapshot you take during the planning scan, the mathematical motion model you build from it, the physical treatment position, and the daily image registration all perfectly describe the exact same physical reality.
And when those elements drift apart, your sophisticated dose calculation is just going to miss the intended target. Or, worse, it exposes critical normal tissue, like the heart or the spinal cord, to doses you never anticipated.
Which is a terrifying prospect.
It is. So our mission today is to tear down that illusion of the perfect digital plan. We're going to extract the core management logic you need for these situations.
Yeah, we aren't just going to list what the new technologies are. We really want to deconstruct exactly how they fail, why they fail, and how you can protect your patient when they do.
To keep us totally grounded in clinical reality, let's anchor this to a specific patient case. You are prepping a patient for curative intent thoracic radiation.
Okay, so the disease-specific indication and the target concept are already established.
Yep, all set. Your patient is on the simulation table, lying supine, arms supported above their head, and a custom immobilization device. Everything looks perfectly standard.
At first glance, sure.
But then, after just a few minutes in that rigid position, you notice their breathing pattern starts becoming really irregular.
And that subtle irregularity immediately introduces a massive complication for your entire treatment course.
Because when you attempt to acquire that 4D CT, the respiratory correlated scan, you see the target appearing in different positions across the different respiratory bins.
Which we expect to some degree, of course. Tumors move.
Right, but you look closer, and several bins show these abrupt, jarring changes in the shape of the target. It absolutely does not look physiologic.
Like a spherical lung nodule suddenly looks like a jagged staircase.
Exactly, or like it's been sliced in half. It looks entirely like a digital artifact, not human anatomy.
So the scam is corrupt.
Yeah. Recognizing this, the team tries to pivot. You decide to attempt a coached breath hold technique. You instruct the patient, monitor their breathing, and they manage to hit the requested breath hold level perfectly.
Let me guess. Exactly once.
Exactly once.
Yeah.
On the subsequent attempts, they miss the mark. They're struggling. And as you keep trying to coach them, you notice on the internal imaging that the anatomy is slowly drifting.
It's not returning to that initial baseline position you captured on the very first try.
Not at all. So this scenario is incredibly common, right?
Oh, it happens every single week in a busy clinic. And it brings us to the core question of this entire review. You shouldn't be asking which motion management technology in our department is the newest.
Right. It's not about the shiny new toy.
Exactly. The real clinical question you need to ask is, which data set and motion management strategy are genuinely reliable enough for this specific patient in front of me?
And what exact image guidance plan will ensure the treatment remains faithful to that strategy every single day for weeks?
Right, because if we can't trust the initial setup and we see the patient actively struggling, how does that translate to the actual scan we get?
This is where the digital illusion starts, right? Since the patient's breathing is erratic and their internal anatomy is physically drifting, we have to look really closely at the very first link in the workflow.
How they are actually positioned on that table. The mechanics of the setup itself are so often the root cause of the failure.
Let's reframe how we view the simulation appointment then.
Yeah, we have to. A simulation is not merely a data acquisition session where you just try to get a pretty picture for the dosimetrist.
It's a test run.
Exactly. It is the first true end-to-end test of whether your proposed treatment workflow can actually be delivered in reality.
Before they even go into the scanner, You need to know what patient limitations might completely undermine reproducibility over a multi-week course.
Right. So let's break down the biomechanics of that standard supine arms-up setup.
It's so ubiquitous in thoracic radiation that we basically treat it as a default setting.
And the logic makes sense from a physics perspective. We need beam clearance.
Yeah, we need the arms out of the way to bring beams in from oblique angles without going through the thick, unpredictable density of the shoulders.
But here's the catch. That position has to be stable and tolerable for the entire anticipated treatment time every single day.
Not just for the 5 minutes it takes to get a quick CT scan during SIM.
Exactly. The physical tolerance is where the theory just completely falls apart in the clinic.
Like supine with arms up using a vac lock bag or a wing board is common, but it's not a commandment written in stone, right?
No, not at all. It fundamentally has to be reproducible without forcing the patient into pain or dyspnea or progressive shoulder strain.
If you have a patient with severe COPD, lying flat on their back might immediately induce a feeling of suffocation.
Or if they have a rotator cuff injury, holding their arms above their head will cause this slow, agonizing muscle tremor to develop over 10 minutes.
And this is exactly where I always push back on that rigid standardization we see in clinics. A beautiful, perfectly symmetrical arms-up scan is completely useless if the patient can't hold it comfortably.
It really is.
I always think of it like trying to tailor a bespoke wedding dress on a rigid plastic mannequin.
Oh, that's a great analogy.
Right, like you measure it perfectly, you stitch it beautifully, it looks flawless in the window. But if the actual bride puts it on and can't take a deep breath without the seams bursting, the dress is a failure.
It doesn't matter how good the math was.
Exactly. If our patient is visibly struggling, shaking, or breathing erratically on the SIM table, shouldn't we deliberately alter those supports right then and there instead of forcing compliance just for a pretty scan?
You absolutely must alter the supports. If the position isn't physically sustainable, change it deliberately. But when you make that change, you have to fully understand the downstream planning consequences.
Like blocking lateral beam arrangements if you bring the arms down.
Right. That might force your planners to use anterior-posterior beams that transit more normal lung tissue. That's a clinical trade-off you have to accept and manage.
And you have to document that modified setup exceptionally well.
Yes. Another therapist on a different machine 3 weeks from now has to be able to recreate it perfectly without relying on memory.
Reproducibility is a property of the whole patient setup, not just the brand of the immobilization device.
Exactly. So once we have a truly tolerable position, we move into dataset validation.
This brings up the massive clinical debate on contrast versus non-contrast scans and the risks of diagnostic image fusion.
Right. The IV contrast question isn't just a simple checkbox on an order. You have to ask what specific anatomy you're trying to distinguish.
Contrast is great for defining mediastinal lymph nodes or separating a central tumor from adjacent blood vessels.
But contrast agents drastically change the Hounsfield units, the density values of the blood vessels on the CT.
And our dose calculation algorithm relies on those Hounsfield units, right?
Yeah, to determine how radiation scatters and deposits energy. If you calculate dose on a contrast-enhanced scan, the computer might think there is dense bone where there is actually just contrast-filled blood.
Which leads to a completely faulty dose calculation.
Exactly. So if you acquire multiple data sets, everyone on the team must know exactly which one is for contouring and which one is strictly for dose calculation.
That makes total sense. Now, what about diagnostic fusions? Say we want to fuse a PET scan to our SIM scan to help outline the tumor.
This is where things get really dangerous. The thorax is a dynamic, constantly moving environment. The lungs are basically biological sponges that twist and stretch with every breath.
So if we use a rigid registration algorithm, one that just shifts and rotates without warping, the fusion might look globally beautiful but be dangerously misleading.
Right near the target we actually care about, rigid registration works wonderfully in the brain because the skull doesn't change shape.
But the thorax deforms massively.
Exactly. When you sit at the contouring workstation, you can't just ask, does this fusion look good overall? You have to ask, which specific piece of anatomy is anchoring this registration?
Because it might align the clavicles perfectly, but be totally misaligned down by the diaphragm where the tumor is.
A global numerical registration score cannot ever replace your localized, slice-by-slice visual inspection.
Okay, so our patient is stabilized. We've got our imaging foundation. Let's look at capturing that moving anatomy. The 4D CT is showing those strange, abrupt, shape changes.
We need to decode this motion model.
What is actually happening inside the computer during a 4D CT acquisition?
To understand the artifacts in our case, you have to know that a 4D CT is not a continuous, real-time movie of every breath. It's a virtual breathing cycle.
Virtual meaning the software pieces it together later.
Right. We place a tracking block on the patient's abdomen to measure their breathing cycle. The scanner is acquiring hundreds of axial slices over time. The software then uses that external waveform as a sorting mechanism.
It looks at the timestamp of every CT slice, matches it to the breathing phase, and drops it into one of 10 distinct bins, like full inhalation, mid-exhalation, etc.
That's the mechanism.
I always think of 4D CT sorting like trying to build a flipbook animation of a running horse.
Oh, I like where this is going.
But instead of a smooth video, you just have a massive pile of random photographs taken over 10 minutes while the horse was running, jogging, and occasionally stopping to eat grass.
Yeah, exactly.
If the horse ran at the exact same speed the whole time, you easily sort the photos into a perfect flipbook. But if the behavior was erratic, the sorting fails.
You try to build a frame of the horse at a full sprint, but accidentally pull a photo of it standing still.
Right, and the resulting image in your flipbook is this monster with 8 legs and 2 heads. That is exactly what happens when our patient's breathing becomes irregular.
That analogy perfectly captures it. Irregular breathing forces the sorting algorithm to place anatomically incompatible slices into the exact same bin.
Because the computer doesn't know what a lung tumor looks like. It only knows timestamps.
Right. If they take a deep breath during couch position A and a shallow breath during position B, the algorithm might paste the top half of a deeply inhaled tumor directly onto the bottom half of a shallowly inhaled tumor.
What does that physically look like to the clinician reviewing the scan?
Oh, you'll see abrupt target discontinuity. The tumor seems to instantly teleport a few millimeters, or you'll see those non-physiologic shape changes.
Like the jagged staircase.
Exactly. Or the most obvious teller, if you look at the respiratory trace recorded by the external monitor, you'll see massive irregularity and shifting baselines.
And our case patient has exactly that glaring warning sign.
Right.
Now, here is where we encounter a major board trap.
A very dangerous one.
As a busy clinician, you see this messy 4D CT. You have 10 other plans to review. It is incredibly tempting to take a shortcut, right? You might think, can't we just look at the maximum intensity projection, the MIP contour, that whole blurred envelope of motion at our usual margin, and just move on?
That is perhaps the most dangerous board trap in thoracic planning, and a terrible clinical habit.
Let's explain what an MIP actually is for the listener.
The MIP is a single summary image. The software looks through all 10 phases of the 4D CT, and for every pixel coordinate, it displays the brightest, most dense pixel it found across the whole breathing cycle.
So it creates this bright, blurred trail showing the path the tumor traveled.
Theoretically, yes, but you absolutely cannot just contour the MIP artifact and move on. It fails when density relationships are unfavorable.
Like if a soft tissue tumor abuts the diaphragm.
Right, they both have similar high densities. The MIP will just smear the tumor and the diaphragm together into one massive bright blob.
And more importantly for our case, if reconstruction artifacts have contaminated the individual phases because of erratic breathing, those exact same artifacts contaminate the MIP.
Exactly. You end up contouring a digital error, a mathematical hallucination, not a physical tumor trajectory.
So a larger planning margin does not magically repair a fundamentally invalid motion model.
No, if you draw a bigger circle around a corrupted MIP, you are not being safe. You're just choosing to irradiate a massive volume of healthy normal tissue based on a flawed assumption.
Increasing the risk of pneumonitis without even guaranteeing you're hitting the target.
You must systematically review the respiratory trace alongside the reconstructed phase images, visually follow the target. If you can't confidently identify it across the whole cycle, you have to call the motion, estimate what it is uncertain.
Do not convert profound uncertainty into a falsely precise margin.
Never.
So for our case patient, the verdict is in. We cannot accept this artifact-laden 4D CT. The team has a major decision to make at the sim console.
First step is consulting your medical physics team. See if the study can be reconstructed using different sorting algorithms, like amplitude-based sorting instead of phase-based.
And if physics can't salvage it,
then you determine if a repeat acquisition is feasible, maybe with better coaching, audio-visual feedback, or just a short rest. Or you need an alternative respiratory assessment.
But the golden rule is you cannot invent a motion envelope out of thin air just because the scanner gave you a flawed image.
Right. Which brings us to selecting the motion management strategy.
Our patient failed the coach breath hold test. The external monitor showed they hit the mark, but internally, the anatomy drifted further away with each attempt.
So how do we systematically select a reliable alternative? Let's clear up a major misconception first.
The myth of the universal numerical threshold.
Oh, this still haunts clinics today. People say, if the tumor moves more than 5 millimeters, I automatically date the treatment. If it's less, I just make an ITV and treat free breathing.
I hear that all the time, treating a single millimeter measurement as if the number itself makes a decision, completely devoid of context.
It is a completely faulty, obsolete conclusion. Relying on a rigid number ignores almost every variable that actually matters.
Like the direction of the motion?
Yes, 5 millimeters of motion inferiorly along the path of the beam is very different from 5 millimeters laterally towards the heart.
It ignores variability, target visibility, and the patient's ability to actually tolerate the method.
A modern approach requires you to synthesize the data. You have to select a reproducible strategy tailored to this patient's physiology.
To structure that, I want to use a framework from our sources. Let's look at a checklist before we even turn the beam on. The START sequence. S-T-A-R-T.
I love this framework.
Let's break it down. S is for strategy. Does this specific motion management strategy actually reduce the physical uncertainty that matters most for this particular plan?
That is the perfect starting point. A strategy that looks highly advanced on paper might not actually solve your specific geometric problem.
Right, like using a complex abdominal compression device for a target in the absolute apex of the lung.
Where motion is already minimal, you haven't reduced meaningful uncertainty, you've just added discomfort for zero dosimetric gain.
Next is T for tolerable. Can the patient physically perform this strategy for every single fraction, for the full duration of the treatment?
Not just once during a 5-minute simulation. This is where our case patient failed. If they fatigue by the third breath hold, their muscles shake, their back arches, and internal anatomy drifts. The method is not tolerable.
And if it's not tolerable, it's unreliable.
You can't force a 20-minute breath hold treatment on a patient who exhausts after 3 minutes.
The A is for anatomy. Can the target, or a carefully justified surrogate, actually be seen well enough on our daily cone beam imaging to verify the position?
This is a harsh reality check. Real-time tumor tracking is entirely useless if you can't reliably visualize the anatomy on the daily low-dose CBCT.
If the tumor is a faint ground glass opacity that vanishes in scatter artifact, you can't track it.
Exactly. You must have verifiable anatomy.
The R stands for resources. Has the workflow software and physical equipment been fully commissioned and quality assured by your local physics team?
You cannot just borrow a phase window from a published paper. If your own team hasn't validated that specific workflow in-house end-to-end, it is not a resource you actually possess.
Using uncommissioned workflows is how catastrophic geographic misses happen.
Absolutely.
And finally, the last T is for trigger. Is there a predefined fallback trigger or clinical plan for when the chosen method inevitably fails?
You must know exactly what you will do when the patient comes in on fraction 10, exhausted from chemo, and suddenly cannot hold their breath.
Do you switch to an ITV? Do you replan entirely?
A technique that cannot explicitly answer all 5 of those START questions should not move forward.
So applying that logic, let's evaluate the options for our patient. We have motion-encompassing approaches like the ITV.
The ITV's main strength is practical. The patient can usually just lie there and breathe freely. It's highly tolerable.
But the vulnerabilities are significant.
Yes. By encompassing the whole trajectory, the treated volume is larger, meaning more normal lung is irradiated. And if the 40CT is flawed, like our patient's, the ITV faithfully reproduces that exact flaw.
Plus, a patient's baseline breathing position can drift wildly over a multi-week course. What about breath hold? It seems appealing because it theoretically freezes the motion.
It can dramatically reduce motion and deliberately separate a target from nearby anatomy, like pulling the heart away from a left-sided lung tumor during a deep inspiration breath hold.
But breath hold is not a default victory just because they do it right once at simulation.
No, the characteristic failure mode, and this is a massive, often silent risk, is internal surrogate decoupling.
Let's really get into that concept, internal surrogate decoupling. Explain the actual biomechanics of how that happens on the table.
It is arguably the most dangerous silent failure in thoracic radiotherapy. Decoupling happens when the external monitored breathing signal matches its intended target perfectly, but the internal anatomy shifts to a completely different position.
So the block on their chest is one thing, the tumor does another.
Exactly. Imagine your patient at sim. They are fresh, they take a deep breath using their diaphragm. The block on their chest rises to a value of 5.0, and the tumor moves down 3 centimeters. Perfect.
Okay, fast forward to fraction 12.
The patient is tired, their back hurts, they can't engage their diaphragm as deeply. So to hit that 5.0 mark on the screen, they subconsciously switch their biomechanics.
They use their chest wall instead of the diaphragm.
Yes. They use intercostal and accessory neck muscles to expand their chest wall outward. The external block rises to exactly 5.0. The computer screen turns green.
But internally?
The diaphragm hasn't moved as much, and the tumor is sitting 2 centimeters higher than it was at simulation. The external trace reached the level, but the internal anatomy did not return to the same place.
Wow. So the external monitor only tells you the surrogate repeated. It doesn't prove the target repeated?
Precisely, and that is exactly what happened to our case patient.
So what about respiratory gating, where we turn the beam on and off based on their breathing cycle?
Gating restricts beam delivery to a pre-selected portion of the cycle, usually end exhalation. But the beam turning off outside the gate does not make it intrinsically safe.
You still have to verify the target is in the right position when the beam is on.
Right. If the baseline lung volume shifts, they start taking shallower breaths, the gate might still trigger. But the tumor is physically a centimeter away from the high-dose region. Irregular breathing completely invalidates the gating model.
What about physical interventions? Abdominal compression?
It restricts the downward excursion of the diaphragm, it reduces motion, but you have to measure the dosimetric effect on the scan, and it can be incredibly uncomfortable.
If it makes them breathe faster or more erratically, the workflow failed.
Absolutely.
And tracking the tumor in real time, moving the beam to follow it.
Highly intuitive in theory, but in practice, it adds extreme technical dependence on target visibility and system latency. It requires a flawless QA chain.
It's not a magic way to avoid assessing motion.
It's a vastly more demanding way of acting upon it. If system latency drifts, tracking can actively steer the beam into normal tissue.
Okay, so for our specific patient, the logic tree is clear. The breath hold is internally inconsistent due to decoupling, and the initial 4D CT is corrupted.
So we either successfully repeat the scan with better coaching to build a reliable ITV, or we utilize a locally validated alternative they can actually tolerate.
And once we make that choice, we have to enforce it. Which leads us to the daily reality check, image guidance or IGRT.
This is the moment of truth. This is where the geometric promise you made at SIM is rigorously tested against reality.
The IGRT prescription must be derived directly from your motion strategy. It cannot be copied and pasted from a generic template.
I see this issue everywhere. A physician spends hours contouring, and then for IGRT instructions, they just type match chest.
Right, and that is not a valid prescription.
Match chest means absolutely nothing. The chest has ribs, vertebrae, carina, heart, diaphragm, and the tumor. A safe instruction must explicitly name the priority anatomy for matching.
Are you aligning to the vertebral bodies, the gross tumor volume itself?
You have to define how to handle disagreements with secondary anatomy and define acceptable residual uncertainty, like match GTV, acceptable bony mismatch up to 3 millimeters.
And this touches on surrogate validity during daily imaging. Just because a rib is nearby and easy to see on a daily cone beam CT doesn't make it a reliable surrogate for a soft tissue target inside the lung.
Exactly. The tumor is floating in a spongy lung. The rib is fixed to the chest wall. They don't move synchronously.
You can't transform the visual convenience of a bright white rib into clinical evidence of where the gray soft tissue tumor is.
You really can't.
Let's put this to the test with a real-world dilemma. Our third major board trap. You're the attending. It's day one on the machine. The therapists call you to the console.
Okay, feeling the pressure already.
The bony match, the stein and ribs, looks perfectly aligned. But the soft tissue target, the actual tumor, is clearly off by several millimeters. The schedule is backed up.
Yeah.
Is it acceptable to just tell the therapist to split the difference between the bone and the soft tissue to be safe?
You must absolutely never do that. Splitting the difference is a terrible, dangerous habit because it produces a correction without any clinical objective, right? Exactly. If you just mathematically average the shifts, you run the massive risk of aligning neither the intended target nor the critical anatomy properly.
You might pull the high-dose volume just far enough off the tumor to cause recurrence, while simultaneously pushing it just close enough to the spinal cord to cause myelopathy.
Averaging shifts is essentially clinical guessing.
So what is the actual corrective action when you're standing there feeling the pressure and seeing that discrepancy?
You must return immediately to the plan-specific registration priority you wrote. Determine whether the target or the surrogate should govern the match.
And if there is an unresolved disagreement near a critical structure, say the tumor alignment pushes the high-dose region into the esophagus.
You do not average the shifts. You escalate.
Escalate meaning what, practically speaking, in the middle of a busy day?
Escalate means you interrupt the treatment for that day it's necessary. You obtain additional imaging. You take the patient off the table, review the match with physics, and determine if the anatomy has fundamentally changed.
Has the tumor shrunk? Did a lung collapse?
Exactly. If the uncertainty remains unresolved beyond your action levels, you do not deliver the beam. Recurrent disagreement is not a daily inconvenience to ignore. It is direct evidence that your planning model may no longer be adequate.
Which flows perfectly into adaptation, interruption triggers, and patient counseling. At what point do we definitively hit the brakes and replan?
You need to define your clinical triggers for adaptation before the first fraction is delivered. Corrupted 4DCTs, inconsistent breath holds demonstrating decoupling, persistent loss of target surrogate consistency.
Or a clinically meaningful anatomy change.
Right.
Like a large tumor rapidly shrinking after fraction 10, or a massive pleural effusion developing.
You must have predefined action limits for these.
We really need to emphasize a cultural point here. Interrupting the workflow, taking the patient off the table without treating, is a successful safety action.
It's a victory of your quality assurance. It is not a failure of throughput.
A pause means your surveillance system worked as intended.
Yes. Stop the treatment, preserve the imaging at the console, figure out the primary problem, and involve the whole team in a review.
Let's talk about plan evaluation and efficiency, too. A highly complex motion workflow, multiple breath holds, frequent cone beams can inadvertently increase patient fatigue.
They're lying on a hard table for 30 minutes. Physical fatigue creates significantly more opportunities for motion error.
So efficiency is actually a critical safety variable.
Yes, efficiency doesn't mean rushing the patient. It means rehearsing the clinical sequence so the patient isn't asked to sustain an unstable setup while the team improvises a solution.
Because a plan isn't acceptable just because the nominal dose volume histogram looks great on paper.
The DVH is a mathematical fantasy if the underlying anatomy cannot be physically reproduced on the table.
The final piece is the human element. How do we communicate all the pauses, extra imaging to our patient without inducing absolute panic?
You have to frame the complexity as a proactive safety measure right from the consultation.
Like saying, because your tumor is in your lung, your breathing changes its position. We are choosing a customized method that we can rigorously verify.
Exactly. On some days, we may take extra images or even pause the treatment if things don't look absolutely perfect. That pause is a strict safety measure to protect your healthy tissue.
I love that phrasing. It makes the physical burden visible, recruits them as an active participant, and frames a paused fraction not as a terrifying complication, but as proof the safety net is working.
You are setting the psychological expectation that true precision requires rigorous verification.
All right, let's lock in this management logic. We're going to distill this down into a highly integrated rapid review.
Let's do it.
We'll run a thought experiment incorporating the core, pearls, and board scenarios. First scenario, you're reviewing a new patient. You measure an 8mm mobile target in the lower lobe. Based on everything we discussed, what's the best immediate next step? Some might say gating is mandatory because it crossed a 5mm threshold.
And others might say just build an ITV. But the only correct answer is that you must assess the full clinical context before selecting a strategy.
So our first major pearl is that a solitary measurement like 8mm does not trigger a mandatory technique.
Gating isn't automatically safer just because you cross a threshold. It requires a validated internal-external relationship. An ITV isn't automatically safer if the scan data is corrupted. You must evaluate motion direction, reproducibility, target visibility, and proximity to critical organs.
Second scenario. Your 4D-CT for that patient shows highly irregular breathing, and several bins have abrupt, jagged shape changes. The MIP produces a massive, blurred, apparent motion envelope.
The temptation is to just contour the entire envelope on the MIP and add a large margin.
But we know that's wrong.
Entirely wrong. This hits on our next two crucial pearls. First, a thoracic planning scan is a mathematical motion model, not a static photograph.
Second, MIPs and average data sets do not replace a rigorous phase-by-phase review. You cannot contour a digital artifact.
Abrupt, non-physiologic shape changes indicate a sorting or reconstruction failure. If you contour the MIP, you're converting a digital sorting error into a treated high-dose volume.
You have to review the trace, validate the phases, and if necessary, replace the corrupted model. And a corollary pearl. Adding a larger margin never repairs corrupted data. It just irradiates more healthy tissue.
Exactly.
Final scenario. We've rebuilt the plan. It's the first day of treatment. You're at the console. The CBCT bone match looks reasonable, but the soft tissue target suggests a different correction, and the target is right next to the esophagus.
We discussed the danger of splitting the difference here.
The absolute rule is to review the plan-specific registration objective and escalate if unresolved.
Precisely. Which anchors our final two pearls? One successful breath hold at simulation does not equal a reliable treatment course. You must verify the reproducibility of the internal anatomy, not just the external signal.
And secondly, your IGRT prescriptions must be exceptionally explicit. State exactly what anatomy to match, how to handle bone versus soft tissue disagreements, and precisely what the stop triggers are.
Image guidance exists to answer a clinical registration question, not just to generate a mathematically moderate shift to keep the schedule moving. You must escalate if you cannot resolve the discrepancy safely.
That brings us to our final provocative thought for this session. I want you to leave mulling this over. True geometric precision in thoracic radiation has absolutely nothing to do with how narrow your gating window is, how small your margins are, or how incredibly expensive your real-time tracking device happens to be.
Not at all.
True precision is the often boring, highly rigorous daily evidence that your patient actually occupies the exact physical and anatomical state your mathematical plan assumes they do, every single fraction.
That is the absolute essence of our field. When that daily evidence disappears, you don't guess. You make the clinical uncertainty visible, you involve the right people, and you restore a fully validated workflow before that beam ever turns on.
In our next exploration, we are going to use these exact planning foundations to dive deeply into early-stage non-small cell lung cancer treatment selection. We'll be weighing the evidence and deciding among surgical resection, SBRT, empiric treatment without biopsy, and ablation. Get show notes and complete practice oral boards at radonsmartlearn.com and subscribe for our next episode. Thanks for tuning in.